So, for frontline patients with targeted treatments in mantle cell lymphoma, that's what we're asking about, correct? Okay. So, as we discussed in the abstract, the recently completed SHINE study was utilizing ibrutinib plus bendamustine and rituximab versus bendamustine and rituximab. There is a sister study to this that is ongoing, and we're awaiting readout, which is the ECHO study. That is utilizing acalabrutinib, which is a second-generation BTK inhibitor, plus bendamustine and rituximab versus bendamustine and rituximab. A slight difference with the ECHO study versus the SHINE study is the ECHO study will allow for crossover, meaning if a patient were to progress on the standard of care arm, they would be able to receive acalabrutinib at disease relapse. There is another study called Mangrove, which is looking at zanubrutinib plus rituximab versus bendamustine and rituximab. This one is a little bit different from the other two studies in that there is no chemotherapy in the experimental arm. It'll be zanubrutinib, which is another second-generation BTK inhibitor alone, plus rituximab. Patients will receive 6 cycles of that and then continue zanubrutinib alone. And then for bendamustine and rituximab, that is only given for 6 cycles. There are some investigator-initiated studies being conducted. There's a study being conducted by the Cornell Group, which is looking at lenalidomide and rituximab plus acalabrutinib in newly diagnosed patients. And then there is a study going in Europe, which is a triangle study, which will look at ibrutinib versus plus RDHAP followed by autologous stem cell transplantation versus RDHAP followed by autologous stem cell transplantation versus ibrutinib RDHAP followed by ibrutinib maintenance for about 2 years. So that's just a snippet. There are obviously more investigator-initiated studies, but I'm sure that would take too long to cover. Yeah, I would say the biggest challenge we have right now is that even with all of these studies that I've mentioned, the ones that I've sort of read out at this point, we've yet to really make a big improvement in the outcomes of patients who have very high-risk disease, especially those who have P53 mutation. So that is an area that we still need further studies to determine whether we can really make improvements in this patient population. And I think with the other thing on the flip side is when we start looking at some of these targeted therapies going into the frontline setting, patient cost becomes an issue, obviously, because these oral medications fall into prescription coverage, and sometimes patients have very high copays. So depending on the state that the patient lives in, what the insurance carrier will provide, and also the time of year, because sometimes we reach out for foundation grants and they will run out at a certain point. It sometimes makes it very difficult for patients to afford some of these novel medications. So that's, at least the two biggest things I could say that, moving forward we'll have to deal with. I think the exciting thing, I'll answer both. I think the exciting thing is that there's been a ton of research into mantle cell lymphoma recently. We have an approval with brexicaptogene autolusa, which is a CAR T product. There are several bispecific antibodies that are being explored, which function very similar to CAR T, except these are off-the-shelf targets, which target CD20. And then we have several antibodies against ROR1, and also a drug antibody conjugate against that target. We have a non-covalent BTK inhibitor that was recently explored and seems to be very efficacious in patients who've already failed some of the more commonly used BTK inhibitors that we have. So pirtobrutinib actually showed to be efficacious in its BTK refractory patient population. So I think moving forward, there'll be tons of options. Hopefully some of these will get indications, will allow us to continue to improve the overall survival of patients with mantle cell lymphoma. I think for the P53 mutated patients, I think some of these T-cell directed therapies will hopefully be the thing that gets us over the hump. These patients had very good outcomes after CAR T, and the hope is that even with the bispecifics, we'll still see very good outcomes in this patient population. And because of the combinability of the bispecifics, the hope is that obviously maybe we can move these agents up in line of therapy or combine with other treatments to improve outcomes.